Welcome, everybody. We're just going to wait 1 minute until everyone has kind of signed on. All right. Welcome everyone to the Young Leaders for Health webinar number 2 in our series covering COVID-19 and mental health, impacts, lessons, and opportunities. My name is Dara Karakoulis. I'm a core team member of Young Leaders for Health, and I will be chairing the webinar today. Next slide, Sophie. So just a little housekeeping. Please kindly mute your microphones if you're not speaking. We will be having a Q&A, so please use the Q&A function to add your comments and questions. There will be a chance to ask your questions later, so if you just add them to the Q&A function, we will answer them in the Q&A portions. As well, we will be recording the webinar, and the slides will be provided after the webinar. And if you would like to live tweet, please use the hashtags YLH webinar and YLH SDGs. Next slide. So for those that aren't familiar with Young Leaders for Health, our aim is to nurture the next generation of leaders in public and global health. Our vision is a healthy, inclusive, equitable, and accountable society, free of structural discrimination, that peacefully coexists with nature. So as one of our initiatives, we host an event called the Social Entrepreneurship Challenge on eHealth, but due to the current pandemic, we had to postpone the event until August 2021. So as a team, we decided that since the topic of mental health is still so incredibly important, we needed to do something to highlight it. Thus the transition to the webinar series. Okay, next slide. On July 9th, we hosted our first webinar on COVID and mental health, and it was focusing on psychosocial considerations for vulnerable populations. So we heard from Alicia Malik from WHO, Priscilla Duia from Women for Refugee Women, as well Rupa Dutt, the co-founder of Women in Global Health, and we also had some speakers from Young Leaders for Health. All the speakers highlighted mental health as well as the role of equity in gender. And the recording and some highlights are available on our website for those who weren't able to join us. And today, our objective is to demonstrate the importance of affordable, high-quality healthcare and strong social systems in achieving universal health coverage, as well addressing mental health disorders and building back better from COVID-19. So next slide. Just to run through what will be happening today. So first we will look at lessons learned from COVID-19 and working towards universal health coverage. Then mental health and the SDGs, achieving health for all. We'll have a Q&A after the two first speakers. Next, we'll move on to some country-specific case studies. We'll hear from 2 different countries, and that will be followed by a final Q&A session. Next slide. Just to introduce our speakers briefly, we have Aditi Kuber from Young Leaders for Health. We have Nicole Votruba, she's a PhD student, Business Development Manager at King's College London, Coordinator at Fundamental SDG. Next slide. We also have Samuel Knauss, physician and neuroscientist at the Charité, and Christopher Laurie, health researcher, health and wellness advocate at Heart and Stroke Foundation, Barbados. So now we will hear from Aditi. Aditi is a member of the organizing committee of the 2020 Social Entrepreneurship Challenge on eHealth. She holds a BA in economics and an MA in development economics with a focus on behavioral economics and global health. She believes in interdisciplinary collaboration with passionate individuals to come up with innovative digital solutions for achieving universal health coverage. All right, and let's hear from Aditi.
Thank you, Dara, for your kind introduction. Hello and welcome everybody. Once again, I'd like to thank all of you on behalf of Young Leaders for Health for joining us today on this webinar series. The focus of my presentation is on how this pandemic has created an urgent need for implementing universal health coverage and what are the steps that we can take towards achieving it. Next, please. So I would like to start by giving a brief introduction about Sustainable Development Goals, or also known as SDGs. The SDGs are, are you able to see my face now? I hope so. Yeah. So the SDGs is an ambitious project implemented by the UN and launched in 2015. It comprises of 17 goals and 169 targets, and these goals range from eradicating poverty and inequality to tackling climate change. All 191 member states have agreed to achieve these goals by 2030. Next, please. The focus of this presentation would be on Goal 3, which focuses on achieving good health and well-being. And this goal is further divided into 9 targets. Next, please. So I would like to start my presentation by giving a before and after analysis of how COVID-19 has impacted the different health outcomes. So taking into account the progress made by Millennium Development Goals along with the launch of SDGs in 2015, there were significant strides that were made by member states in achieving selected health outcomes. For example, since 2000, maternal deaths have been decreased by 37%, and over 6.2 malaria deaths have been averted between 2000 and 2015, primarily in the age group of under 5 in sub-Saharan Africa. In terms of other communicable diseases, there are over 36.9 million people still living infected with HIV, and only 21.7 million people have access to antiretroviral therapy. Next, please. The coronavirus pandemic has had substantial health, social, and economic impacts in all countries, rich and poor alike. For example, illness and deaths from communicable diseases will increase sharply, and also thousands of additional under 5 deaths may be expected in 2020. Most countries, especially poor countries, have insufficient health facilities, medical supplies, and healthcare workers for the surge of this demand. Next, please. Which brings us to this target 8 of Goal 3 that focuses on achieving universal health coverage. Universal health coverage improves how healthcare is financed and delivered, so it is more accessible, more equitable, and more effective. Next, please. According to the definition proposed by the World Health Organization, universal health coverage means that all people receive quality health services that meet their needs without exposing them to financial hardship in paying for them. Numerous studies have shown that universal health coverage is a smart investment and an achievable goal everywhere. Next, please. So why do we need universal health coverage? I've listed some points there, but also I'd like to share some facts. For example, worldwide, 400 million people lack the most basic life-saving healthcare services, and almost 17% of the people living in low and middle-income countries are pushed further into poverty because of healthcare spendings. The Ebola crisis has been a stark reminder and the urgent need to facilitate for universal health coverage. UHC also pays a resilience divide. In times of distress, health minimizes the shocks to lives and livelihood. In times of calm, it promotes community cohesion and economic productivity. Next, please. So paving the way forward, since we are in this critical juncture of how we can progress with this goal and how we can achieve universal health coverage, we are facing this dual challenge of responding to the coronavirus outbreak and maintaining essential services. It is encouraging to think differently and how to be better prepared for emergencies that make progress towards universal health coverage. The UHC movement has not only focused on ensuring that healthcare services are accessible and affordable, but it also relies heavily on disease prevention, health promotion, and emergency preparedness. Next, please. So to conclude, I'd like to share this poignant photo project with all of you, which is financed by the Rockefeller Foundation. Every day we are exposed to numerous data visualizations and statistics, but sometimes we tend to forget that behind every data point is a person who has lost their life battling a threatening disease or died due to lack of proper medical care. So let's strive to create a world where access to quality healthcare should never depend on where you live, how much money you have, or your race, gender, or age. Thank you. Next, please.
Great, thank you, Aditi, for the insightful overview about UHC. And next slide, I think it's 2 more down. Perfect. And just kind of going off of what Aditi had just talked about, we had a really lovely post by Shreya from Young Leaders for Health, and it's about, the title is "One Size Does Not Fit All," and it's a cross-country overview of mental health response to COVID. So if you're interested, please take a look at that. It's on our website. And now we will be hearing from Nicole. She is a researcher at the Institute of Psychiatry and Psychology and Neuroscience at King's College London, working on mental health in low and middle income countries, the UN SDGs, knowledge translation to policy, stigma and suicide prevention, human rights in mental health. She is also the co-lead of the Indigo Local Project, working on developing interventions to reduce stigma through media campaigns in low and middle income countries. So without further ado, Nicole.
Hi everyone, thanks Dara for the introduction. Can you hear me and see me well?
Yeah.
Okay, good. All right, I just see that I'm not sure what happened to the slides. Is this the PDF that I sent, or I'm just hoping it's the right version, but.
Yes, it's the PDF, but we just had to convert it into a PowerPoint.
Oh, all right, yeah, okay. Good, thanks. Okay, so yeah, I'm very happy to be here. I think it's a really important topic and it's a great initiative that you're doing with Young Leaders for Health. So yeah, I'll just dive in. I'll try to briefly point out the relevance of mental health within the United Nations Sustainable Development Goals, how we can work for mental health in order to achieve health for all, even under situations currently like the pandemic, COVID-19. Next slide, please. Okay, so I'm gonna be pointing out, so first I'm gonna talk about the relevance of mental health for the SDGs. And then I'm going to be, sorry about the ordering, sorry about the, I think it was a transfer issue. But anyway, then next point is going to be to tell you a bit more about where and how mental health ranges inside the SDGs. I'm going to stress the potential impact and the implications that COVID-19 might have on mental health, and then how we can strengthen mental health through the SDGs. Next slide, please. Okay, so why is mental health relevant for the SDGs? Next slide, please. Okay, so we can see overall there's a growing burden of disease and mental illness. 1 in 4 people have a mental health condition in the course of their life. And as a result of that, 600 million people are currently worldwide disabled. And for instance, we can see that depression is one of the leading causes of burden of diseases currently. Next slide, please. Mental illness or mental disorders are also a leading cause of mortality and early deaths. So we can see that men who have a mental health condition die 20 years earlier, and women die 15 years earlier if they are ill compared to people who don't have a mental health condition. And we can see that suicide is the second leading cause of death, particularly in young males, and it's increasing. So we can see it's actually a killer disease. It's not just feeling unwell. Next slide, please. And what we can see is that there was a systematic review that found that 14.3% of deaths worldwide can be attributed to mental illness, and that mental health conditions therefore rank among the most substantial causes of death worldwide. Next slide, please. And all these things are true for high-income countries. So we can see these numbers apply for high-income countries, but it's far worse in low and middle-income countries. So we can see that most people, when we look at the world, most people actually live in low and middle income countries. And that means that most people with mental health conditions also live in low and middle income countries. And we can see that in low income, can you move to the next slide, please? Yeah, thank you. So in low income countries, we have a very low provision of mental health services. And on this slide, you can see it's a study. They looked at prevalence of mental health conditions and treatments as the treatment gap, the number of people who receive treatment versus the number of people who actually are in need of receiving mental health treatment. And we can see that it's already pretty bad if we compare high income countries with low and middle income countries. But we particularly see it when it comes to mental disorders, where the situation is bad already in high income countries, but less than 10% for severe conditions get treated in low and middle income countries. Next slide, please. This is a study that was conducted that compared Ethiopia and Denmark, Finland, and Sweden, the deaths, so years of life lost, early deaths, premature mortality. And as you can see in the red columns, it's excessively higher in Ethiopia compared to other countries, particularly for females, but also for males. Next slide, please. And also, of course, we see severe human rights violations in people with mental disorders. On this picture, you see a patient who has schizophrenia, and he'd been chained for many years in India before he received treatment by an organization called SCARF, and he's well now. So yeah, thanks. Next slide, please. Okay, so I hope this showed the relevance. So where is mental health in the SDGs? Next slide, please. So when we go back, there was a first generation of sustainable development goals, and they were called Millennium Development Goals. They were started in 2000, and they had a particular focus on health. So they were mainly health goals, and they were really successful in specific areas. Sadly, mental health did not get included in these Millennium Development Goals. So when 2015, the new generation of Sustainable Development Goals was approaching, it became clear that mental health was yet again going to be ignored. Next slide, please. So leaders in global mental health, such as Professor Sir Graham Thornycroft and Vikram Patel, issued a call to the United Nations and to all the states and called upon them for including mental health among the new Sustainable Development Goals. Next slide, please. And Graham Thornycroft, who has been advocating for strong mental health in global health and in global mental health for decades, he founded an organization called Fundamental SDG, and I was coordinator of that. And so from 2014 to 2016, we were advocating the United Nations Sustainable Development Goals committees and countries to gain support. And if you're interested, you can go on the website and have a look on what we did. And then next slide, please. So we got support from different countries on the issue, and even Kofi Annan, former Secretary General of the United Nations, spoke out in London in 2014 and stressed that we need to place mental health and depression in particular within the new SDG agenda. Next slide, please. And then you can just move on. Okay, so next slide, please. So we then, no, sorry, can you go back one? Thank you. So, so where is mental health in the SDGs? So we can see that in the preamble to the SDGs, it is stressed as a development priority. And mental health did eventually not get its own SDG or its own goal, but it's included in the health goal. And there are 3 targets with indicators that relate to mental health. One's on prevention, treatment, and promotion of mental health. One's on substance abuse. And one is universal health coverage, as we've already heard before. And these indicators are really important because they're actually what gets measured in the end by countries. And so countries will be collecting data and will be improving their situations as they can and as they choose. So there are 167 indicators, I believe. So it is a difficult and a challenging task. So mental health does risk to not get dropped off, even though there is a number of indicators. Next slide, please. And what we also see is that mental health crosscuts the SDGs. And this is something that doesn't strongly feature within the declaration of the SDGs, but we can see that there's a strong cross-links between poverty, hunger, other health conditions, education, and even as we see climate action, as we see it now with situations that health conditions or environmental conditions that impact on health and mental health conditions that have interlinks. Next slide, please. And these are called socioeconomic influences on mental health and vice versa. So we can see, as just stressed, like poverty or unemployment or crime will have negative effect on mental health. And we have conducive factors such as a safe living environment, housing, a good neighborhood, physical health, and social networks will improve mental health and have a positive impact. Next slide, please. And this has also been stressed by Vikram Patel and the Lancet Commission in 2018. It was the Lancet Commission on Global Mental Health and Sustainable Development. And they pointed out the relevance and the potential of the Sustainable Development Goals in embracing these interlinks and these crosslinks. Next slide, please. So what is the impact now that we have COVID-19 and the potential implications that we might have to deal with or we have to deal with in terms of mental health? Next slide, please. So 2 days ago, colleagues of mine from the same institute at King's College London have published this study, and they measured with the General Health Questionnaire, which is a simple questionnaire to measure mental health, general mental health in people. They looked at people in the UK, how their mental health or mental distress changed compared to years before 2018 and 19, when they were 1 month into lockdown, so into isolation, essentially. And they found that the mental distress in people rose from 18.9% in 2018-19 to almost 30% in April 2020. And yeah, we can see this effect was particularly increased with young people. Next slide, please. So what we can see, I'm just going to point out quickly a few points. So we can see that substance use, alcohol drinking increased. So in orange, you can see what happened in lockdown. The numbers increased in the different age groups, particularly middle-aged. Next slide, please. We can see that people felt more lonely. There's an increase in loneliness, which also affects depression and anxiety. Next slide, please. And what we can see here on this picture is mass graves in Brazil, which is tragic. And so these deaths that are occurring, as Dara said before, they're actually a person that leaves an entire network of people who are then in grief and have to deal with that, and sometimes even several people that they might lose. So this is a massive impact on mental health. And then next slide, please. We can also see that it impacts mental health services. So they saw, this is from Dublin, they found that there was a dramatic increase in admissions for severe conditions in mental health hospitals. But at the same time, we also see that fewer people dared to go out when they were in lockdown to access services. Next slide, please. So these are impact factors for mental health. I've pointed out a few, and increased risks are for first responders, older people, children and adolescents, people living in poverty or in humanitarian and conflict settings. Next, please. The potential implications that we're facing is increases in demand, lack of mental health support. There might be a risk of reduction because funding might be moved to other health areas. We can see that these impacts might be particularly severe for people living in poverty, low quality work, unemployed, homeless, disabled, or in conflict settings. And there's a risk of deprioritization of the SDGs and those mental health targets as a result of that. Next slide, please. So how can we strengthen them? What can we do? Next slide, please. So the UN Secretary General, Dr. Tedros, has issued in May a policy brief to minimize the consequences of mental health negative impacts on the world through COVID-19. And he points out 3 priorities for rapid implementation. 1 is a whole society approach. 2, widespread availability of emergency support. And 3, building mental health services that are protective for the future. So I'm not sure how much time I have, but next slide, please. It's only a few more slides. Just to briefly point out maybe these points. So the whole society approach means that mental health actions are essential components of the national response to COVID-19, and this needs to be integrated. So really looking at changing response, national response across all relevant sectors. Next slide, please. When we look at the second target, then it's a widespread availability of emergency mental health support. And this means it must be available, these services must be available in any emergency. And it means investing into these interventions that can be delivered also remotely and will guard human rights of people. Next slide, please. And 3, it's building mental health services for the future. So that means an investment is needed to protect all affected communities and to give them access to mental health, quality mental health services, as in universal healthcare provided. So integrating them in universal health coverage, including financial benefits and insurance schemes, and also have a community-based service, have an approach and really integrate mental health into communities. Next slide, please. This is also something that will be or is laid out in more details and in foundation in the Mental Health Action Plan, if you want to look it up. And MHGAP is something that is more widely used in low and middle income settings where there's no professional or experts, psychiatrist in place. There is, next slide, please. There's also a very helpful tool, which is the Basic Psychosocial Skills Guide for COVID-19 first responders. It's been translated into a couple of languages. It's accessible on the WHO website or through the Interagency Standing Committee. I've put the link in here. And then next slide, please. Yeah. So what is important when we think about mental health in the current situation? It's very much needed more than ever to support. But there is a risk, but there's also an opportunity. So we cannot lose sight, and we must not lose sight of mental health within these goals, because it's essential. And maybe this is the time where societies also realize how much in need they are in order to support long-term societies for their mental health and physical health and beyond. Thank you. Next slide, please. Yeah, I've put in a few resources, and then next few slides you can just run through. Yeah, I thank my colleagues, Professor Thornycroft and others. And if you want to contact me, get in touch. Yeah, thank you for listening.
Thank you so much, Nicole. Just for the sake of time, to make sure that we get through all the presentations, we're going to do all the Q&A at the end. So next we will move on to Samuel. He is a physician and neuroscientist at Charité. He has years of experience in the planning and implementation of scientific evaluation of projects in digital health with a focus on digital global health. He is also the co-founder of the project MTOMED. He is responsible for the development and implementation of digital solutions for healthcare financing in Madagascar. He is a research group leader of the Charité Global Digital Health Lab, project leader of the Berlin Institute of Health's Digital Health Accelerator and Digital Clinician Scientist Program. So thank you, and let's hear from Samuel.
Yeah, thank you, Dara, and thank you for the invitation and opportunity to speak in this webinar. So I've been asked to, next slide, please. Have to get used to this. I have been asked to talk a little bit about our work in Madagascar, and in particular about the impact of the lack of universal health coverage and the impact of COVID-19 in this scenario. Next slide, please. So Madagascar is an exemplary low-income country in sub-Saharan Africa, which is just a little below even the average in sub-Saharan Africa. So 92% live below the poverty line on the $2 per day line. The health expenditure per capita per year is, even compared to other sub-Saharan African countries, very, very low, with 14 euros per year per person. And also the average of nurses per 1,000 people is less than half of the sub-Saharan African average. So next slide, please. So if you look at mental health and neurology in particular, and neurology is very dear to me as a neurologist in this context, then this is the actual numbers of neurologists and psychiatrists in Madagascar. So this is not per 1,000 or per 100,000 or whatever, this is actual people. And that's for a population of 26, next slide, or next 26 million people on the island. So the impact of COVID-19 is on two levels, and that's, I think, also the two main parts of universal health coverage. And one is actually accessibilities. So when it's hard to reach a neurologist or a psychiatrist in a country where there are 26 million people, it's a huge country, it's larger than France, and there are 14 psychiatrists, and then you have a lockdown, that becomes even harder. But it's also on the financial side that access, when there is a scarcity of resources and of psychiatrists, access becomes harder. So next slide, please. So me and my colleague and the co-founder of MTOMED, Dr. Julius Emmerich, we have been working in sub-Saharan Africa for the last 10 years, doing basic medical support missions. But what, in our experience, one of the difficult or most difficult situations always is when people can't access essential healthcare for financial reasons. So we run the only ambulance service in the rural south of Madagascar, and it's a common situation where people stand in front of the ambulance and have their relatives unloaded in life-threatening conditions because they're so afraid of the cost. Next slide, please. Next slide. And this is not the one before. So this is a problem that not only affects people in Madagascar, and it not only affects people in the rural south of Madagascar, but it affects more than 800 million people in sub-Saharan Africa because they lack access to health coverage or any form of health insurance or comprehensive state-funded healthcare. Next slide. And that's despite great efforts of the international community and of local businesses to create a network of health insurances, of micro health insurances, and state-funded healthcare schemes in sub-Saharan Africa. Next slide. But really, the reach of these schemes is very limited by a pen and paper-based process. We are involved in this in the south. We have, in the last 10 years, have build a pen and paper based substitute fund to support the poorest families. But again, this is exemplary for a lack of standardized workflows, a lack of structured data, a high business risk for insurances and also government run schemes, and a lack of data exchange. Next slide. At the same time, in a hospital we've been working with for the last 10 years, and that's a hospital in a village where in 2013 there was not a single mobile phone because there just was no mobile phone tower. And this hospital in 2017 received more than half of its revenue over mobile money. So we really set to change the way healthcare financing works. Next slide, please. So we've built on the mobile money infrastructure to connect the beneficiaries and the insurances more directly and connect them together with the hospital. Next slide. And that is what we are trying to do with the Mtomadi project. Next slide. So we currently are the largest payment provider, a digital payment provider in Madagascar. Play the video, please. And patients can access the platform and can access financial support and health financing solutions over a simple phone. So there's no internet connection required, there's no smartphone required. Any phone works, building on the USSD and the mobile money infrastructure. Next slide. And for the healthcare providers, play the video, please. For the healthcare providers, it's a tablet-based application which also works offline and is simplifying the process of filing a claim, of handing in a reimbursement application, and which can be filed in just under 30 seconds. Next slide. So what we're trying to do here is really connecting these stakeholders and giving beneficiaries access to treatment, giving beneficiaries access to healthcare financing, but at the same time also increasing the fraud protection for health insurances or government-run schemes and the quality of care. We are integrating with other digital health frameworks like the District Health Information System, which is the one of the national health information systems in Madagascar, and other initiatives. Next slide. So this is a photography of last week, and it's one of the outreach activities we're doing in the COVID in the COVID time. We're very grateful that we're now able to do this work again, and I think that's also highlighting a challenge in Madagascar, at least, where a lot of medical support and medical treatments are supplied by NGOs or are supported by NGOs, and the work not only of Doctors from Madagascar but of all NGOs has been very limited until now, and the fear is now that this is going to continue or getting worse in the next future. But another thing I wanted to point out here in this picture is we did a survey with these women, and more than 90% of them had access to a phone. So we really believe that the digital technology and mobile technology can make a huge difference in the effort to achieve universal health coverage. Next slide. So this is a team behind Mtomadi. It's a diverse team from people coming from multiple backgrounds. Most of the largest part of our team is in Madagascar, and we're very grateful for the support, especially of Dr. Zava, who's running the medical side in Madagascar, and Nelson, who is running the operations in Madagascar. So thank you very much, and happy to take any questions later on at the Q&A session, I believe.
Yes, exactly. Thank you so much, Samuel. It was really interesting to see from a country-specific level. And now we're going to hear from another country. We will be hearing from Christopher Laurie. He is a trained medical anthropologist, researcher, and health advocate. His focuses include psychosocial determinants of health and the protection and empowerment of vulnerable communities. In Barbados, he works with the Heart and Stroke Foundation to address childhood obesity through advocacy for nutrition policies and public health education. So let's hear from Christopher.
Hi, thanks for the introduction, Dara. So as Dara started to mention, my particular background is in medical anthropology. I would have studied in Jamaica and in London at the University College of London, initially in social anthropology and medical anthropology. And what I try to specialize in, or what I try to focus on throughout my academic career and now profession, is a kind of NCD management and the psychosocial and social determinants that go into how NCDs and mental health here specifically precipitates and is manifested throughout the society. So next slide. All right, so just to set the context, Barbados is a Caribbean island. We have a small geographical footprint, 166 square miles, with a population of roughly 287,000, sorry. It's a predominantly Black population, and we are English speaking with a Bajan dialect. And the picture on the right-hand side of the screen is just to give you a brief kind of overview of how COVID has impacted all of this. So we are a largely tourism-based economy. And now this age-old adage of I live where you vacation is now disrupted in the time of COVID. So where we used to vacation is now a totally different landscape. So next slide. And just to give you a relative timeline of our experience with COVID in Barbados. So on May the 17th, earlier this year, March the 17th, sorry, we would have registered our first 2 cases. These were imported cases of persons who had come back and repatriated Barbadians. And when we talk about, you'd hear a lot of international talks speaking about flattening the curve. You can see a relative kind of plateau after a while. This would have been in response to the kind of measures that and procedures and protocols which Barbados would have implemented. We were under a national curfew for a couple of weeks. We would have shut our borders, and this would have helped to taper off that experience. So next slide. Now, the government of Barbados was very swift in action. We implemented a national COVID hotline where persons could phone in and get information about the virus, about how the government was dealing it, and also to have directed care and a kind of redirection towards any kind of applicable services, whether you wanted to understand if you were at risk for the virus or if you wanted general information. And this across all platforms. So the Government Information Service would have been the hub of this information. And you'll see at the top, I've just made reference to the number of logos that rolled across all social media platforms, Facebook, Twitter. It was as accessible, at least through the internet, as possible. It also would have played repeatedly on the airways through radio and television. So the government tried its best, and it must be commended that we would have had multiple formats and multiple media through which you could access information. So next slide. And this just gives a kind of snapshot, and each day we would have received updates from our Ministry of Education on our situation dashboard. So it would have given a worldwide overview as well as a local situation. So to date, we have had 106 confirmed cases with 8 persons in isolation. 3 persons were actually released yesterday, so we are at 5. And overall, we've been able to contain our death rate, which has been fortuitous, not in terms of the numbers of deaths, but how we have been able to manage and mitigate that kind of loss that we see globally. But what is important to note about this number is that of these 7 persons, all of them had some kind of pre-existing condition, whether it was diabetes, hypertension, or both. And that's important when we start to understand our vulnerable communities of which I work with the Heart and Stroke Foundation and our coalition members. Next slide. And as we will understand, I believe from our previous speakers that one person, one organization, one agency cannot do this alone or cannot do this in isolation. So there was an initial multi-sectoral and continued multi-sectoral response. So we had the government agencies, we had various kind of lay communities pop up or support groups, different services for our vulnerable communities, kind of NCD, civil society organization oriented groups, as well as private psychosocial services. Under the NCD focused civil society organizations, the one I work with is the first, HSF Barbados. That's our Heart and Stroke Foundation of Barbados, in collaboration with a number of NCD-oriented, non-communicable disease-oriented organizations. We would have provided different services, and we moved to more of a tele-based, telehealth and telemedicine-oriented service. So next slide. But what does this mean for mental health in Barbados? Now, while there were provisions for these services to be accounted for, and while COVID was indeed recognized and acknowledged as a problem, we must also anticipate the context in which we're working with. Now, traditionally, unfortunately, in the Caribbean, and Barbados is no exemption, how mental health services were initially delivered and conceptualized was that we took on a kind of colonial European model, where persons who express and manifested symptoms of mental health disorders were treated in what was called lunatic asylums and madhouses. And unfortunately, this kind of stigma is pervasive to this day. So in the circle which I would have highlighted, that call for stop the Jenkins label, that is in reference to our initial psychiatric hospital, where it was housed at an old plantation house in Jenkinsville. And those kind of symbolic descriptors continue to this day. So when you talk about accessing mental health care in Barbados, our primary facility for that at the psychiatric hospital is still referenced as, oh, you're going to Jenkins, you're going to the mental, you're going to, you're going to this kind of deviant place within society. And this stigma creates a barrier to care. So next slide. And again, just continuing on from that point, in understanding how we can roll out universal health coverage under the mandate of SDG 3.8. Barbados actually does have relatively universal access to healthcare. We have the the psychiatric hospital, which I referenced earlier, as well as these district satellite hospitals and polyclinics, which do have outpatient and inpatient clinics. But when COVID-19 hit the island, a lot of these services were now shut down and they had restricted access. And this was not only to healthcare services, but across all facets of society. So restaurants and businesses would have closed. We now have to adapt to this new world that we live in. And of course, COVID, as the previous speakers would have alluded to, created additional stressors, and some of the pre-existing stressors would have been exacerbated. So the little cartoon there is speaking to that kind of notion whereby if we had underlying conditions or conditions which were not readily acknowledged or understood, when we are faced with this new kind of additional stressor, we don't understand or we don't recognize how and why this is affecting us, then we think that this is fine. And we do not know how to access, we don't know where to access these kind of services that are available. And this creates a barrier because on one hand, you already have this preconceived notion that you don't want to be ascribed this kind of deviant identifier in thinking that you have to access mental health services, but you also do not acknowledge how this can affect you in everyday life. So last slide, I believe. Right, so how does this all tie together. So universal health coverage, I think there's a question mark, equality to equity. It should be an arrow. So the idea is you want to push from the kind of equal services which are in theory on paper available to all persons across the island to a more equitable approach where everyone understands and starts to recognize that we're all vulnerable within our own circumstance. And then how do we start to mitigate? How do we start to build resilience measures so that COVID as a continuous and dynamic pandemic continues onwards? If we are faced with further stressors, how do we start to build better for those, for that kind of continuous stress environment? And I've made some recommendations here. So you can start to look at mental health and acknowledge that it does exist on a spectrum. So the idea that all persons can be equally affected. And I think that in a kind of odd way, COVID has been a universal equalizer. And if we do not recognize that, if we don't recognize that we have all been equally affected by this, we miss an opportunity to start to build in these resilience measures. And looking at a life course approach, as I alluded to, so understanding that all persons can be co-equally affected, although in unique ways. And then meeting people where they are. So building these communities of support. Barbados is a predominantly Christian society. So when I made allusions to these religious groups, you can work with these pre-existing organizations which already have membership and which already have this kind of core basis and an organizational structure, and work with them to be able to build in this resilience training and to have that continuous assessment, continuous understanding of what mental health is and how it manifests. And then you can also look at having a workplace reimagine and contingency plan for when you do ask people to come back. You don't expect them to necessarily produce at the same rate and in the same fashion. And you have these kind of open discussions, open dialogue, and you just create a culture of support and a culture of understanding around mental health and mental wellness, and again, how it all affects us equally, not just for COVID, but going forward. And this feeds into the idea of safe spaces where people feel comfortable to express that they are feeling that this is affecting them. And then finally, you recognize kind of unique vulnerabilities within your individual population. So for Barbados, we do have an aged population. This number from the World Health Organization goes back to 2016. But when I checked the World Bank database, they actually said that we have an average life expectancy now of 79. And we know that non-communicable diseases do tend to pop up in later ages, although we are seeing them at earlier stages. We also have our essential workers who are tasked with answering the call to action, but are also equally being affected at the same time that they're working within the environment. And then again, we have our NCD communities. So for me, working with the Heart and Stroke Foundation and with our coalition members all looking at childhood obesity, we have recognized that in our individual spaces and in our individual organizations, people were coming forward now. And when I made the allusion to the 7 persons who had passed from COVID in the country, all of those individuals were unfortunately also affected with comorbid symptoms and expressions of non-communicable diseases, whether it's diabetes, hypertension, obesity, etc. And so when you add these additional layers of stressors onto that, then you can see how that they can be disproportionately affected. And there were also more and more persons coming forward to try to access these services, which were now not even available because we were on a national shutdown. So that loss of access is going to create anxiety within the community, and that's not just for COVID, that is moving forward into any kind of disaster, which brings me to the final point where the Caribbean is geographically located in a vulnerable location. As we sit here today, we actually have a hurricane on its way that is targeted to hit Barbados, or at least pass by Barbados in the next 2 days. So in a very real way, we understand that these kind of natural disasters, we always have to have this kind of resilience training and resilience approach, and mental health cannot exist only as a reactionary measure. It has to be built into your preparedness and disaster preparedness model. We see other examples throughout the Caribbean, these kind of unfortunate incidences with our Caribbean neighbors, where we have the Bahamas, we have Puerto Rico, we have Antigua and Barbuda, and these people are still recovering from hurricanes which would have occurred 2-3 years ago. In the Bahamas, for Hurricane Dorian last year, they would have had a $3.4 billion loss of GDP just from that incident alone, which accounted for almost 30% of their total budget. So what is important and unique about the Caribbean environment is that we do not have the kind of access to international aid, even though we're categorized as lower income countries, because on the vulnerability index, we are perceived as graduated. So we are being hit hardest by the kind of global warming and environmental challenges, while not being able to recover adequately. And that kind of redirection, that kind of allocation of funds, while you do understand in a very obvious and real way that you have to take care of the people, you have to manage the situation as it's happening, you also have to account for these long-term effects. So mental health is going to manifest in the moment, and it's going to manifest later down. And the kind of anxiety which builds from all of these things that are happening concurrently, then you can start to understand in a very real way how small island developing states such as Barbados, such as all of us in the Caribbean, can be affected by COVID and any kind of natural disaster. And I think that is it.
Thank you so much, Chris, for the closer look at what's happening on the country and community level within Barbados. So now we're going to go to our Q&A discussion, and we have a question for each of the speakers, but I just ask that you keep it brief, 1 or 2 sentences, just addressing the question. So we will start with Aditi. The question is, what would be the new normal for health systems and UHC?
Thank you, Dara, for the question. I think the new normal would be investing in primary healthcare, and governments should be working more closely with local communities. And also there has to be a lot of focus on 3, like PPE, which is prevention, protection, and emergency preparedness. It also calls the need to invest in healthcare financing, because even though it has shown, even though there has been a lot of economic recession and it has severely impacted financial situation in a lot of countries, it just shows the need of the hour that we really need to focus on investing in better healthcare systems, because I think if we have better healthcare systems, people will be more resilient towards these unprecedented shocks. Thank you.
Thank you, Aditi. And now this question is for Nicole. What do you believe will be the main driver to push for more mental health coverage in the SDGs and for universal health coverage?
Hi, the main driver globally, you mean, or I mean, I think it's unclear whether how much impact there is and how much driver can be. Hopefully, a main driver. I mean, I'm assuming, depending on the numbers of severe cases we see and implications and mental health effects. Also in terms of deaths, that's often something where policy then reacts and takes actions. I'm hoping it doesn't have to be as grave as that, but yeah, hopefully countries will realize that, and groups like this one can stress the relevance of integrating mental health for making it happen.
So more advocacy on different levels. Okay, thank you. And then for Samuel, what are some challenges experienced in scaling up the project that you're working on in Madagascar?
There are a lot of challenges. So I think one of the biggest challenges is, of course, the local setting. So, I mean, offline capability and infrastructure, although improving very, very rapidly, still is a problem when it comes to rural and remote areas. So we have to work very hard to make it as simple as possible. Then another challenge is the partner. So we are working with governments, and that's great. That's the goal, to enable universal health coverage on a government level. But that is a slow and long-term process. And then we are working with a number of partners to enable access to financial services in healthcare quicker, and that comes with its own challenges. Working with a lot of different partners is always difficult, and to enable really a multi-payer system, harmonize processes at different partners, that is a great challenge.
Okay, thank you. And then finally, Chris, we would like to know what resources are available for young persons dealing with mental health in Barbados.
Well, I think that from the outset, there are a number of peer-to-peer support groups. There are a number of organizations who I interact with, the Rotary Barbados, for instance, and we have kind of continuous mentorship and continuous kind of lay support. Now, the psychosocial support is delivered primarily through the psychiatric hospital, but again, we have to appreciate the context of which we're working with and the kind of mental stigma that is built up around that. So in the sense of moving towards universal health care and moving from the equal access to that equitable access, we have to understand that different persons are going to express differently. Mental health is going to be manifested differently. So it's just to have those continuous conversations. Because not everyone in a very real way is going to have the kind of financial economic access to private care. There are services available, but they're not as readily accessible.
Great, thank you. And I just want to thank the panelists again. Thank you so much for your presentations. As well, thank you for everyone that has joined us today. We will be having our final webinar of the series on August 6th, and it will be at the same time at 4 p.m. Central European Time. And we will be highlighting digital mental health and emerging research and treatments. So the webinar from today will be, since it's been recorded, and will be posted on our website, as well as some kind of follow-up highlight documents. So please keep checking our website and our social medias. And everyone have a lovely day or evening, depending on where you are. Thank you.
Thank you. Bye.
Bye.
Bye-bye. Have a nice evening, everyone.